Hi everybody, it's Melissa again from AIM. Tonight we're going to talk about all things scans. So we're going to talk about chest x-rays, we're going to talk about CT scans, MRI, PET CT, a little bit about how they work, how they image. I brought a prop so I can show you how you're positioned in the machine and how that equates to photos. And then this sounds really good in my head, but I did get some examples of different images so you can see exactly what we see when we look at the scans, and I can show you where there are actual tumors on some of these scan examples that I have. So hopefully it'll make a little bit more sense. Tish, this is recorded to view later. It'll show up on the Facebook page for a long time and eventually on the YouTube account. So, but yeah, so tonight's it's all things scans. I did want to mention, and I'll mention this again, I hope that you don't get dizzy because I'm going to be switching or trying to switch the view so I can show you some things on my computer in front of you. So this is the best setup that I could think of. Hopefully this will work out. In my head, it sounded really good, so we'll see. So anyway, first let's talk about scans in general. Will everyone get imaging for their melanoma? No. Early stage melanomas, in a lot of places, people don't actually do surveillance imaging, and other places do. So it's very doctor specific, just so that you know, starting off. There are some generalized recommendations regarding surveillance as part of the National Cancer Institute's and guidelines that were set. But really, this is kind of an individualized part of care. So if you have concerns about why you aren't getting scans, certainly ask your doctor. You can ask me if you want. I'm always available. We can try to figure it out. So without further ado, let's talk about scans. I will try at the end to hit as many questions if I don't see them as we go along. So the first thing I want to talk about is a little bit about radiation. So everyone is really worried about doing or getting radiation in regard to these imaging modalities. And truly, part of the goal as treating physicians is to make sure that we minimize that as much as possible. There isn't as much radiation as you would think in these scans. There was a radiologist at Hillman Cancer Center that actually talked about radiation in reference to flights. And again, this is probably not super accurate in terms of exact numbers, but he said that because we're exposed to X-ray radiation every day, just living, he said that a chest X-ray would be as if you got on a commercial airline and flew across a couple of states. That's about how much radiation you get exposed to. A CT scan would be if you took a plane from Pennsylvania to Seattle. And a PET scan would be if you got on a plane and you flew from Pennsylvania all the way around and back to Europe. So, obviously PET CT scans have the most radiation, chest x-rays have the least radiation, and then there's MRIs that don't use radiation at all and instead use sound waves and magnetic rays. So a little bit different. Chest x-rays are probably the most widely used imaging modality across not only oncology but other centers because it's easy, it's accessible. A lot of places, even outpatient clinics, a lot of times will have a chest x-ray on site. There's no prep involved. It's cheap. You can look at a lot of different structures. In our particular setting in melanoma, we typically use chest x-rays as surveillance for lung nodules. And the reason for that is that chest x-rays can actually pick up lung nodules that are 2 and 3 millimeters in size because it's looking at it in a blanket front to back modality. So if this is the plate that the x-ray, images to, and this is the actual radiation that goes, you're going from front to back. And so what you see is a good front to back picture of what is going on in the lung. So it's sort of like a photograph, looking at a photograph. The downside is it's two-dimensional. So a lot of times if we do see a lung nodule on a chest x-ray, we'll follow up with a CT to confirm that it is actually there and not a shadow from something on the gown or something on your skin or a nipple shadow, because that can sometimes happen. So it's very low radiation, it's non-invasive, those are all great things. The cons are that it's two-dimensional. It's not very detailed, so you'll see, I'm going to try to bring up this one picture that shows some really good lung nodules. You'll see from this photo that actually the picture's kind of hazy, so it's not super detailed. You can see, the scapula bone or your collarbone, and you can see the ribs, and you can see the outline of the heart. This is the gastric air bubble. So there are a lot of structures that you can actually see. I outlined a picture of where there are 2 lung nodules just so that you can make it a little bit easier. Sometimes it can be really hard. Sometimes those outlines are extremely faint. So it can sometimes be a difficult read, but you can see things that are extremely tiny. Now, this, for example, down here, I'm gonna get this out of the way. Even though it looks like an itty bitty nodule, it's actually just a blood vessel turned on its side. So sometimes, those kinds of artifacts will show up on a chest x-ray that makes it a little difficult to follow. Oh, now I can't get out of here. Hold on. See, this is what happens in live television. Okay, so while I try to figure that out, we'll talk a little bit more about the other parts of the chest x-ray. I don't know why that won't let me do it. Hold on. Anyway, we might be done using that because it doesn't seem to go back. Escape. There we go. Never mind, I fixed it. Okay, so I think we have a pretty good idea of chest x-ray. It's simple. We can use it to survey for lung nodules. Sometimes you can even see some soft tissue disease. Here's another example, now that I know how to fix it, of a chest x-ray with a lung nodule on it. And here it actually is a little bit easier to see. It's a little more defined. It's out in the corner. It's extremely circular, so it's a lot easier to see. And you can see again, there are these little tiny nodules that look like, okay, they maybe could be something, but those are actually blood vessels as well. So just a little bit about chest x-rays. More detailed and a little bit more expensive and also more radiation is a CT scan. So CT scans, I will tell you, are primarily what we use in our clinic to survey our patients that especially have metastatic disease. We use chest x-rays in people that, Lori, like in your case, you found it and you didn't know it was there. We use chest x-rays in our case to survey patients that are, stage 1, stage 2, sometimes stage 3 patients that have undergone treatment. Now, that doesn't mean that every clinic is going to do that, but that's certainly how our clinic particularly, accounts for the possibility that you could develop lung nodules from a melanoma. Because of all those reasons. It's cheap, you get a good picture, it's very fast, there's no prep, simple dimple. Okay. CT scans are a lot more detailed than chest x-rays, but they also bring about some challenges. So the good things about CT scans are that you can look at organs, you can look at blood vessels, you can look at soft tissue lesions, bones. So you can look at a lot of things. As long as the person that's looking at it, radiologists or physicians, know their anatomy, anything that shows up in there that doesn't belong is most likely something that doesn't belong and it needs to be addressed. So it's extremely detailed. It shows anatomy really well. It gives you a 3D picture. So when you are the person in the scanner, the machine actually is around you. So like this. And so what it does is it kind of moves like this and it's imaging you in a circle. So when your scans come out, it's sort of like, so when I look at them, it is your feet are pointing towards me and it cuts you like this from above. And so you get slices through the body. So it's a 3-dimensional picture. It's actually really cool. And you can see lots and lots of things on a CT scan. So I'm going to bring up a CT scan here that shows lung nodules. So in this particular instance, now this is a lung field. So the things that you're looking for here are that because the lungs are very filled with air. They don't have a lot of density, so they appear black. Things that are more dense than air will show up as white. So that's where this is a lung nodule that doesn't belong there. This tiny itty bitty thing right here is a lung nodule, but all of these little guys that are around these blood vessels and bronchioles are actually blood vessels. So they are not actually lung nodules, but you can see that very clearly that is a lung nodule of melanoma. Now, another scan that I want to show you is pneumonitis. So this is the other thing that you can see on scans. You can see infectious processes like pneumonia or COVID. And so here's a really good example. This isn't tumor. This is actually pneumonia or mucus that has formed in here because of pneumonitis or inflammation of the lung that happens from immunotherapy. So CT scans are really great as diagnostic tools because you can see a lot of different things and make interpretations that you couldn't do with a chest x-ray. So that's sort of the limitations that a chest x-ray poses. Another example is you can see here in the liver. So in this case, all of this background black is actually the body cavity that holds your organs. So it's going to be obviously not very dense. The liver has a middle density, so it appears gray. And in this case, tumors in the liver will either appear dark where there is necrosis or where, the tumor is lacking blood supply and starts to die, with little bits of tumor interspersed, or sometimes the tumor will appear as a darker spot, which will appear lighter. So obviously this is something that comes with time and looking at scans, but I just wanted to give you guys a good picture of what we look like. So in this particular instance, this person's laying like this, and this is a cut right here through her liver. So you can see a kidney and a spleen and the liver, and that's part of her stomach. So you can see everything that you want to see. Let me see, I think I have one more good picture of CT scans here that shows you a soft tissue nodule. So I just wanted to make sure that I let you see that. So in this film, what we're looking at that's a lymph node or a soft tissue nodule that you can feel under the skin on the left-hand side of the person's upper arm. So again, because this is the person laying like this and it's a cut right here, this is actually left and this is actually right. So it's cool. So we can see inside of you anytime we want. So that is what a CT scan looks like. So let's go back to pros and cons. So the pros, you can look at pretty much any organ. Muscle, bone, tissue, everything, bones in great detail. So that's a positive. The second thing is it gives you a 3D picture. The third thing, it's relatively quick. So unless you're doing a bowel prep, which is oral contrast, the actual scan itself takes about 15 to 30 minutes. So you don't lay down for a really long time. So folks that have, difficulty with pain and things like that, the scan itself is pretty fast. The con is that you have to use contrast to enhance the images that you see. And the contrast takes on two forms. You can do oral contrast, which helps us see solid organs, hollow organs like the bowel, and it helps enhance parts of the liver. It helps enhance the gastric mucosa, and it helps lymph nodes. So we like contrast because it helps us see lymph nodes and structures that are otherwise hollow. Oral contrast is important for that reason. It takes about an hour to drink the stuff. It's not tasty. A lot of times folks will have GI upset, either diarrhea or nausea from the oral contrast, but it is super helpful in looking for tumors in those places. We also use IV contrast, which can pose a problem for people that have kidney disease because if the creatinine is really high and your kidneys aren't working really well to filter normal things, when we give it contrast, it has to work extra hard. And so sometimes for those patients, if we run into issues with that, we'll sometimes give them half dose contrast. We'll sometimes give them oral hydration after their, or IV hydration after their scans. So there's ways around it, but that does pose a problem for folks that have kidney disease. Also allergic reaction. So I've seen a couple of folks that are watching that I know have contrast allergies. And so it limits our ability to use these detailed CT scans because of the fact that they're allergic to CT guide. So Sally, that's what I'm just talking about. So CT scans without contrast sometimes are okay if your sites of disease are not in the liver, like if you have lung nodules or you have soft tissue disease, you can see all of those things without contrast. And radiologists can read scans without contrast. They're just not super detailed, so it doesn't help the oncologist very much. But radiologists, that's what they do all day. They literally sit in a room and look at scans. So, whether your doctor chooses to do non-contrasted CTs or do PET CTs as your surveillance is really up to them. There's no right or wrong thing, and we'll actually talk about why PET scans might not be great for surveillance in a second. But it all depends. It's very, very individualized based upon where your disease is and a whole bunch of other things. So I know that's not really an answer, but there's really not a wrong answer in this case. The other thing about CT scans that's a con is that you can't use it in pregnancy. With chest x-rays, you can kind of shield the belly if you absolutely needed a chest x-ray for some reason. It's not recommended, but you could do it in a pinch. But really for pregnant patients, we really don't want to do CTs unless we have no choice. The other con is that you have to fast for a CT scan unless it's of the lung, and even then they kind of want you to, but especially for an abdominal CT, you would have to fast. All right, I think we're clear on that. So the next thing I want to talk about is MRI. So MRI is great because it doesn't require radiation. In our setting, we primarily use MRIs to look at brain, to look at bone metastases, to look at spinal tumors, and for ocular, I know somebody earlier had asked about ocular melanoma. We try very hard to get insurance to approve MRIs for surveillance for the liver. A lot of times that doesn't happen because of insurance, and so we use ultrasound in those cases. But when possible, we like MRIs for surveying livers for ocular melanoma. The way that an MRI works is same thing. You lay in the thing, although it's really close. So instead of, the bowl being around like this, it's actually more like this. And it almost feels like you could touch your nose to the top. You can't, but it feels that way because it's very, very tight. And the reason for that is that the MRI is a really, really strong magnetic field and radio waves, and they are applied at 100 million different directions. And that causes the atoms that are inside your body to react and give off a signal. And the signal goes back to the machine and it arranges it in a way that looks like an organ or your body. So it's actually really cool science, but the reason that it's so close like that is that if you were pushing out radio waves from way up here, there's a lot of interference in between. And that's why they do make wide bore MRIs, but they're not as detailed and accurate because the radio waves have too far to travel. So when you want to use radio waves, and magnetic rays, you want it to be really close to the body so that there's no artifact or interference with those in between. So I hope that at least explains a little bit better how an MRI works and why does it have to be so close so that you're super, super claustrophobic. The pros to an MRI, before I show you some pictures, are that obviously it's not radiation. It's okay to use in pregnancy for that reason because you're not radiating anyone. As long as the pregnant person can fit in the MRI machine, you're in business. It does give really good detail with anatomy, just like a CT scan. It is also 3D. And it's good for a lot of structures. I mean, you can even do MRIs of the lung if you absolutely had to and could not do CTs or other modalities. And especially this is prevalent in pregnant women. You can do an MRI of pretty much any part of your body as well. So widely used. The bad thing is that MRIs are extremely expensive. More so, almost as much as PET scans, but more so than the other screening tools. MRIs are extremely, extremely expensive. A lot of patients have difficulties with claustrophobia because they're so tight. Metallic objects like clips, pacemakers, artificial joints, you have to really be careful. And sometimes it's a contraindication to using, especially with pacemakers, they have to be turned off to getting an MRI because the radiomagnetic waves can actually interfere with that. It does use contrast in a lot of cases. The contrast is a special one called gadolinium. It's less likely that people would be allergic to that, which is good. But there's not as much detail as a CT scan. CTs really have the best detail of all of the imaging modalities, but it does give great detail. Buddy, what is the name or purpose of the thing that's put on top of the abdomen before an MRI? So really all of the structures that they put onto your body, whether it be on your head or your abdomen or whatever, is to keep you from moving, because movement can affect those waves and make the image very distorted. I tried with all of my might to find an image of a distorted MRI in my collection of scans, and I couldn't find one. And I think it's because they take as many precautions as possible to keep you as still as possible. I hope that answers that question. So let's take a look at some MRIs just so that you can see what those look like. So here is an example of a brain MRI. And this is what it looks like. So again, we're looking at your head as if you're laying down like this, and the part of you that we're seeing is we're cutting like right about here on the nose. And so the tumor in this particular instance is this little white guy right here. So again, we're looking at density differences based upon whatever type. So MRIs give different waves. Like on some of the images, the tumor in that case would look dark, but in this case it looks white. The other thing to note, and it's going to be kind of hard because the image is kind of far away, is that around the tumor there's this darker area, and that actually represents swelling. So if I didn't take a screenshot of this and could move the image up and down, you could actually see the swelling, or it's called edema, around the tumor. And that's actually really common, especially with melanoma, because they cause a lot of inflammation and they do have a lot of blood vessels. And so a lot of times you'll see, and hopefully you don't, but patients that have brain metastases, a lot of times will have swelling around them. And that is what typically causes the symptoms of numbness, headache, and the other neurologic things. So that is what an MRI of the brain looks like. Here is what an MRI of the spine looks like. So in this case, you have the patient standing, and this is the MRI looking at it this way. But in the machine, that would mean that the transducers, or the MRI part that is giving the radio waves, is actually around the body this direction, not up and down. And so what you see here these are the vertebrae. In between this darker area, which is actually less dense, are the discs. Now, the thing that gets a little bit confusing when looking at an MRI of the spine is that this looks like it's less dense. But, because tumor is less dense than bone. So people expect that, like, when you're looking at a tumor, you see white spots. That's actually sclerosed bone or scarred bone. This is actually what a tumor looks like. So it looks dark. One, because it's less dense than bone, and two, because even after this is radiated, a lot of times either scar or a hole will form in there, and you won't actually see the tumor anymore. So a lot of times, patients want to see their scans, and they're like, well, I had radiation to that tumor. Why didn't it shrink? And the reason is truly that once you get a hole, I always try to use this analogy, and I don't know if it's completely wrong from a medical standpoint, but it's like when you drill a hole in wood, the wood doesn't regenerate itself. It might, like in a tree, it might form a scar or a knot, but that hole just might stay there. So even though the hole's not getting bigger, the hole might just not be getting smaller. So just so that, that's what, the MRI would show. Tammy, I'm going to go back and look at all the comments once I'm done, because I'm kind of on a roll right now. So, let's see what else. Okay, so that is an MRI. The last thing that I want to talk about is actually PET-CT. PET-CT scans get a bad rap because people want to do the PET-CT scans for everything, because they think, the PET-CT will show everything that happened. Unfortunately, with PET-CTs, in some cases it's really helpful. In other cases, it can lead you down roads of needing additional biopsies and things that wouldn't otherwise be necessary because they're falsely positive. So let me explain that. So the way that a PET scan works is that it shows activity in parts of the body that use energy. So what does that mean? I don't know if anybody has seen Predator movies. So it's that heat vision that the Predator uses to find the people in the house. So, for example, like if you would stand outside of your house and look at your house with PET scan vision, what you would see is an area of heat where the furnace is, and an area of uptake where the oven is if it's on, and an area of uptake where there are light bulbs that are on. So it's really it's almost like a thermal scan, because the more activity that a structure has, the more active or more intensely that it's burning sugar in this case. So essentially what a PET scan does is that it's like a form of like sugar reagent, like a tracer that's attached to a radioisotope. So when it's injected into your body and you have to sit there and let it do its thing, cells that take up the tracer, because they're more active and they're using the sugar, will set off like a flare because they release the isotope. And so what you're seeing on a PET CT is actually this release of the radioisotope to say, hey, we used a bunch of sugar. Cancer cells, because they are extremely greedy little buggers and want to eat all of the sugar and do all the growing, and because they're typically cancer cells in any kind of malignancy are rapidly dividing, they burn sugar faster than normal cheek cells or arm cells or hand cells or whatever. So PET scans are great at looking at flare of cancer cells. Now, the downsides of this are that sometimes they can show activity in a place that is infectious. Sometimes, and this is such a mistake, and I'll never forget this as long as I live, the patient didn't have anything to eat all day and didn't want to have stinky breath, put gum in their cheek when they went in for the PET scan, and the radiologist had the hardest time figuring out why there was this intense radioactive uptake in the person's mouth. And it wasn't until they got upstairs and we did some digging that we figured out it was because they had a piece of gum in their mouth. So, things like that can cause it. If you had an infection in a lymph node, or you had a recent pneumonia, or, we're healing from surgery, that can cause falsely elevated areas to be positive on scans. Conversely, if you have a very slow growing tumor, sometimes that won't show up as positive on a PET because the activity is low because it's not dividing and burning sugar appropriately. What it can show, however, is response to treatment. So if you have a PET scan at the beginning of your therapy and there's lots and lots of places that are lighting up, and then you get a treatment, say the BRAF MEK inhibitor, and you still have the tumors, but they're not hot on the PET anymore, that is a radiologic response because you've turned the metabolism of the tumor from super, super active to not active anymore. You do have to fast for a PET scan for 4 or more hours. And actually people that have diabetes, your diabetic control has to be really tight and have, relatively reasonable levels of blood sugar, or else the PET scan can't be done because of the fact that it so heavily relies on this metabolism of the tracer, which is like glucose. So that's another downside to the PET scan. The other downside that I want to mention is that tumors have to be at least 1 centimeter to be necessarily hot on a PET. So, like Sandra, when you're looking at like how accurate is a normal contrast CT scan, it's actually pretty accurate in terms of letting us know that something is there that doesn't belong. Now, does that mean that that's something that is there as a tumor? Not necessarily. And that's where using a PET scan can be really helpful, because if you have a lesion that's greater than 1 centimeter, you can do a PET scan, and if it's hot, then it's most likely a cancer of some kind. One thing that a PET scan isn't great at is showing those structures on CT scan. So even when you do a co-registered PET and CT together, they don't, because they're giving you this contrast for the PET part, they don't necessarily give you contrast for the CT scan. And so, because of that, the CT images that go with the PET are not very detailed. So, a lot of times instead of doing, a PET CT and expecting to be able to look at structures, we'll do a PET CT with what's called attenuation only. And if there are areas So it shows you structures, and that's actually what this image here, this is an example of a PET with CT attenuation. So you can see that you can see the heart, because that's a structure. This is the liver, or the top of the liver. You can see the bones and muscles because they shouldn't uptake. But the detail, like if you had a tiny little tumor in your liver, you're not going to see it. This is a really good example of a soft tissue or a lymph node that is hot on a PET scan. So the brighter the color, so, white is the hottest, and, dark means that it's not hot or negative. So, like this, all of this kind of structure here is part of the normal breast tissue and chest wall. And this is the lymph node that you can see has a really FDG avid hotspot. I want to show you one example to illustrate this next point. When you are looking at structures that already have a lot of metabolism, like the brain and the liver, really small tumors can get lost in there. And so that's another pitfall of PET scans because, like for example, this is a tumor, but it has a background already of uptake because the liver is constantly doing its job. So in actuality, when you look at a contrasted CT scan, there are actually several more tumors that are scattered throughout this area that doesn't look like it's hot. So that's one thing and one benefit, and why in some cases we like CT scans a little bit better because of the detail that you can see. Another example of small tumors getting lost is in this brain. So obviously the brain is burning sugar, probably the most of any organ in your body. And you can see that it's diffusely hot. That's actually the tumor. It's cold in this particular image, but when it was hot, it was almost the same color as the surrounding tissue. So that's another instance where, sometimes in places like the brain and the liver, very small tumors could potentially get lost. So even though PETs have a really great allocation in certain situations, they're not, they're not 100%, and it's not the end all be all. If your PET scan is completely negative, that's 100% awesome, and we're super happy, and we'll jump up and down with you in clinic. But in terms of following disease over time, it's much more accurate. So Doug, like you're right, like CT scans sometimes can pick up things that like active tumors because they will show activity. CT scans don't show that. But what we see with response to tumors in CT scans is that if a tumor was this big and now all of a sudden it's this big, then it's working. But the pitfall of a PET scan is that it may not pick up tiny itty bitty things in places that are metabolically active, like the brain and the lung and the liver, and sometimes are falsely negative in the lung. So I'm not saying PET scans are bad. PET scans are great. CT scans are great. All of these modalities have different purposes in different situations. That's really the purpose of this talk tonight, is to try to explain a little bit more about how each of the scans work, so that when your doctor is ordering a specific test, you're not second guessing them because you think you need something different. That's my main purpose of tonight. So, because the more you know, the more you understand why we do the crazy things that we do. The other thing is that the PET scans are really expensive. And so there's a lot of times that, insurance companies don't want to pay for them. So, sometimes unfortunately we have to do and sadly dictate some of our imaging modalities based upon what your insurance will cover. So let me go back and try to answer some of these questions because I know there was tons and tons. Is there much more radiation from a PET as opposed to a CT? Yeah, it's almost like 10 times as much radiation, because they have to put you through once to figure out where all your structures are. Then they give you the isotope and then they put you through again, but it goes like super slow, like almost half the speed as what you would pass through for a CT scan. A good example is a normal CT of the chest, abdomen, and pelvis takes about 30-ish minutes, even with putting in the IV contrast. And a normal PET scan actually is 2 hours. So they put you in and then they turn you around and they put you in the other direction to get your legs. So scans are a lot more, PET scans are much more radiation than CTs. Tish says, is there a correlation between the size of a tumor and its energy consumption rate that's measured by PET? Yes. So, and that's part of why small tumors, they don't have enough of a metabolic rate to cause enough of a flare sometimes. And so the general rule of thumb is that a nodule or tumor has to be about a centimeter for it to even be possible to show up as positive on a PET scan. There are some exceptions to that rule with like lymph nodes, but the general rule of thumb is that it has to be bigger than a centimeter. Now, there are some exceptions to that exception, and that is when tumors get to be like really big, sometimes they won't diffusely be positive because areas of the tumor become less enriched with blood, and so only the active parts will actually light up. So bigger tumors in general should use more sugar, so they would tend to be possibly bigger in terms of response in FDG avidity, but that's not always the case. It's actually how active the tumor actually is. So how rapidly it's dividing to burn up that sugar. So it's not so much size as it is activity, if that makes sense. Let's go back and look and see. Doug, we talked about your CTs and PETs. Sally, what is your opinion on insurance denying an MRI in a patient with brain tumors? That would be weird. So a lot of times, you know, if it was 25 years ago, they might say that there are limitations in terms of timing. If there are active brain mets, I don't think I've ever had an experience where we haven't gotten an MRI approved. Usually the general rule of thumb for surveillance, like if you had a brain met, say in the year 2000, and you never had another one and it's now 2008, sometimes they will only allow for like one MRI a year unless you're having symptoms. So they're, you know, but again, it's very individualized with your insurance policy and what the insurance company will agree to. I think we do like 3 or 4 peer-to-peers a week because scans get denied initially, and we have to explain ourselves as to why we want them to happen. And as long as your doctor has a good rationale, a lot of times those insurance will approve them. We do have exceptions to that rule, but you know, it's very individualized. Is there a standard of how often to get PET and CT scans for a stage 3 melanoma after surgery and immunotherapy? No. And actually this is a big debate across oncologists in terms of like how frequently in our particular clinic. And again, this is just the way, and actually our doctor and a doctor that works in our practice order scans very, very differently. But my particular doctor that I work for does a scan at baseline before we start immunotherapy, and then a scan at the end. And then we don't do any more like PET or CT scans unless we were following something that we saw in one of those films, or the patient develops new nodularity or new symptoms, something like that. We just do chest x-rays for those patients because in theory they shouldn't have disease. So that's how we kind of do it in our clinic. But again, there's no steadfast rule, for that in stage 3. For stage 4, the general rule of thumb is most people are getting scanned every like 12 weeks or 3 months while they're on treatment. And then that, you know, as your scans are negative or okay, your oncologist may spread that out. We talked about that. Sorry, I'm just trying to like go really quickly through these. Tammy, you said, my doctor's been doing a watch and wait, not sure what we're waiting for, and getting a PET CT scan every year. Is that a good or bad thing for causing additional problems? Probably if you're having just one scan a year, that's not a huge amount of radiation that's additional. They have seen with PET CT scans that, you know, and there are reports out there, not necessarily with melanoma, but with other cancers, that, you know, repeated imaging can create other malignancies. And that's why there's really this balancing act between surveying patients and not causing harm. So, you know, sometimes when doctors say, you know, we don't need to scan you, it's because they truly don't think they need to scan you. Buddy, we use all of those different kinds of contrasts. So a lot of times we'll talk to the radiologist to see what they want to use. We use Eovist more in our clinic, but really any of them, is fine. Let me look. I'm sorry, this is like so distracting. So Sally, I think we talked about your contrast allergy question. So Buddy, you say, I requested a whole body PET-CT scan, but was told that MRI is the standard of care for ocular melanoma. For the reasons of things getting obscured by the liver because of uptake, PET-CT scans aren't great for surveillance for ocular. Really, MRI or ultrasound are actually better than a PET-CT scan, believe it or not, for looking at the liver in those instances. And hopefully, Buddy, you were listening whenever I showed the picture of the liver with the tiny tumors. Yeah, so I think this is the point where I've really got all of that. So, all right. So, I really appreciate everybody listening. I know that, additional questions might come up. You can reach me either on the AIM at Melanoma page. There's a form that you can fill out. There's also a toll-free number that you can reach me if you have questions. You can use the chat feature. I take all questions, and I'm always happy to try to make sure that everyone is informed and knows exactly what's going on. I did want to mention that in the line of all of this talk about scans, and I hope, in seeing some of the pictures and seeing how things work, we really understand the differences between the scans at this point. Dr. Lou, who does our Beyond the Clinic series, is actually having a guest called Claire Castleman, and she's going to talk about scanxiety and the emotional issues that are accompanied getting CT scans and PET scans and MRIs and the weeks leading up to it and when you're having the scans. And I think it's going to be an amazing talk. I know that scanxiety is super real. Patients experience it all the time in our clinic. So I really hope that everybody will tune in and watch that because it's going to be really, really helpful. She's pretty amazing. Dr. Lou's amazing. So that's going to be their topic in April. So watch out for notifications about that. And otherwise, it was awesome talking to everyone. Hopefully, flipping back the camera back and forth wasn't too distracting and we learned some things about scans. I will talk to you all next month. Have a wonderful evening. Bye.